Oh, oh, Hey,
Hello, John.
how are you doing?
I'm good, thank you. I just wanted to ask you to make me a panelist. Just a
Okay.
second.
Yeah, let me make you,
Co-host, maybe?
oh, yeah. Well, you've been a good girl, so I'll let you be co-host.
Thank you so much. This is our eighth. Just a second. Okay, I think I should change my background. Otherwise,
Yeah, a good
John,
idea.
John will mind. I know
Yeah,
that.
no, it'd be nice, if you individualize it. Yeah, that would be nice. You don't have to, you can put your own personal one, like if you want to put something from, Uzbekistan or something else, whatever you want. That's fine if you want.
Sir
But
has.
so
Mhm.
when you go to Nepal, I mean India. When you
I
going
have
to
to be
India?
in India in 10 days, I hope. So I'm
Wow,
waiting for my visa. And I got my Indian license, so temporary registration.
that was pretty fast. 10 days. Wow.
Yeah, it was no, it was not fast. I was waiting for a few months,
Oh,
so but
because that
finally,
needs help. He needs help.
yeah,
Promoting, like doing his webcast. No, he can. We can continue on, but it would help him. It would help him.
mhm.
I'm sure.
Just a second. Okay, great. So Ravi sir is here. Good morning, sir. Um,
Any cancellations?
No, no, no.
Oh wow. Everyone's coming in the last minute. I mean, we're gonna have a lot of people just on the speakers. Wow.
Mhm. Just a second, John. I have to inform few people. Um,
Good day, Ravi. Ravi, let me get my camera up.
Yes, Travis sir is a neurosurgeon from Bangalore. Today is
Good
our
morning.
good morning, sir.
Nice to meet
Hello.
you.
Yeah,
Nice to meet
let me get back. I'll be back in a second.
you. Yes, John.
I don't want to get naked on
Like,
camera again.
mhm.
We have some more time for starting the meeting, isn't it?
Yes, we do have at least 15 minutes.
15 minutes, okay.
So, sir, you are working in Apollo Corporate Hospitals, right?
Yes,
Okay.
Apollo Corporate Hospital. I was in a government hospital, National Hospital, Sri Chitra
Oh,
Tirunal
Shukra.
Hospital
In
in
Kerala.
Trivandrum. Yeah, in Trivandrum for 10 years.
Wow, great. Because I was last year in Trivandrum, then I went to Kottayam because I love Kerala. So
Ah,
decided to visit. Then I went to Bangalore in April. You
oh, I
probably
see.
know Dr. Sampath Prasad Rao.
Yeah,
He's an
yeah.
ENT Kalbi. So we went for his course, uh,
Okay,
Kalbi. So this time,
wonderful.
yes, this time I'm planning to come to Bangalore, I guess April as well.
Oh, then you should visit us.
Yes, definitely I will. In Sri Chitra, you were working with Suresh Nair sir, right? I
Yes,
think Sri Chitra
yes.
is.
I left in 2010
Ah, okay.
as professor of neurosurgery.
Hmm.
And since 2010, I'm in private sector. That's the corporate
Okay.
sector
Basically, you are from originally
from Bangalore.
from Bangalore. Okay.
Yeah. I came back to my hometown.
Hmm.
And, I've been here since then.
Great.
So you will be The host and the moderator of the grand round says?
The moderator, we have one Russian moderator, Dr. Andrei Dubovoi. He's a neurovascular, one of the famous neurovascular surgeons in Russia. And the second one is international moderator. He's young neurosurgeon from Indonesia, Rifki Aulia. So he will introduce the two young neurosurgeons, and I will introduce them.
Dr. Rifki Aulia and Dr. Andrei Dubovoi.
Yes.
When you say young, hello, Dr. Rao, how are you doing?
I'm very good. How are you, sir?
Good, John Bennett.
This is your first time?
When you say old, Nagisa, how you mean like old, like
young and old?
Like 55, like 55?
No, I think young neurosurgeons consider it up to 40 years old, I guess, yes,
good.
According to WFNS
classification. 50 years old.
Okay, 50.
Young.
So.
You're from Bangalore. That's the internet capital of India,
Bangalore,
right?
yes.
Bangalore?
It's the Silicon Valley of India, considered.
Yeah, right. That's where a lot of internet companies are, like Intel and stuff like that. Have you been there, Nargisa?
Yes, I have been. I loved Bangalore, especially your new airport is something else.
Really?
So not
the
only
new airport is very good.
Yes.
The second terminal, T2, is good.
How's the internet? That's my only question. How's the internet at the airport?
How's?
It's fast.
Internet. Do you have a lot of places to access the internet?
Yeah, Wi-Fi is there, and that's the public Wi-Fi. So if you need private Wi-Fi, you will have to access through your phone.
Oh, okay.
Yeah, that's not a problem, John. So,
yeah. Because the public internet, what you do will be visible to many others.
Yes, sir. So
yeah. Hopefully, yeah, it's going to be broadband. The whole world, but probably within 5 years. Well, man, I'm just guessing.
Okay, so great.
Anastasia, how are you today?
Hello.
I'm Dr. Bennett. I'm Dr. Bennett, and you know Nargisa, I think, right?
No, John, I have to tell you one thing. Anastasia
You don't have to tell me. Is this true secrets?
She's my best friend, like best friend.
Oh my God. Oh, okay.
Nice to meet you.
Okay. She admits that, right?
Yes.
John, Nargisa.
Hello, Andre. Welcome back. You've
Hello.
You've been here a lot.
Dr. Andrei, are we able to see you today?
Yes.
Oh, great.
I'm reinstall my Windows on my laptop, and now the camera working very well.
Great, perfect.
You know, if you want to put a background on, you can, Andre. We can show you real quick.
Maybe now.
Yeah, okay. Let me just show you. You can do it real quick. Go to the video camera to the right. There's a menu. Open that next to the camera. There's a little menu. Open that up.
Okay, I just find it.
Yeah, choose virtual background.
Okay.
And then you can search your computer.
Blurring first of all.
Yeah, choose choose a background from your hard drive.
Okay.
If anyone wants to, train their presentation, you can share your screen. Anastasia, would you like?
Yes. I'd like. Yes.
Проверь, пожалуйста, если хочешь.
Svetlana, good day. How are you?
Hi.
Hello.
John Bennett. Do you know Maritza? Do you know Nargisa?
Yeah, we haven't met.
Anastasia.
All you guys are buddies,
Great.
huh?
Anastasia, perfect. So we are able to see everything.
Okay.
So now stop sharing your screen.
Так.
Остановить, как там?
Есть пауза.
Там как фраза поделиться экраном.
You're gonna help me, Anastasia, with Nargisa, man. Oh man, she's very demanding. She always wants to make my picture bigger. Make my picture bigger.
Все, окей.
I'm not asking too many things, John. Все получилось. Is
А,
that you can share screen and then stop sharing screen. Там есть опция. Как,
Yeah,
Андрей, на
we're
русском
gonna,
остановить?
yeah, I like to start it off
не могу
showing the
найти.
face, really.
Остановить демонстрацию экрана. Stop
Нет,
sharing
поскольку
screen.
у меня есть продолжить и паузу поставить.
А,
М,
так,
Она идет еще? Она еще идет?
Да, но мы видим твой экран.
Ага. Интересно.
Так. Может быть, я могу остановить, потому что я ко-хост, Андрей Владимирович. Здесь есть
Да.
у меня функция
Yes,
Stop
yes.
Participant Sharing.
You can stop. Yes.
Okay.
Все?
Все, you stop.
Окей, окей, окей. Мгм.
So, your friends, what part of Russia are they from, Nargiza?
Yes, when I was doing my residency in Siberia, Anastasia was working as a neurologist, epileptologist there. So this
Now,
is
was that with Tayuman? At Tayuman?
no,
Was
no,
that?
Novosibirsk. Novosibirsk.
Oh, okay, that's way up, right?
It's
That's
called.
inland. It's inland, right? It's a big city inland.
Yes,
And
it's the third biggest city in Russia. So
oh,
after
okay.
Moscow and Saint Petersburg, there is Novosibirsk.
It must be a big hospital there. Big trauma center, right, Anastasia?
Yes.
Yeah.
Right now, Anastasia is working in Burdenko Institute. I think this is the
Oh,
most
wow.
famous institute in
Yeah,
Russia.
of course. I've heard of that.
Everyone knows.
We've had webinars with residents from there. And certainly we'd like to have connections there too, Anastasia. If you
Svetlana is
ever,
also from Burdenko Institute.
Yeah, we work together now with
oh, great. Yeah, if you guys ever want to have a webcast now, Giza, with Burdenko, we'd love to do that. If they want to televise, if they want to televise something, anything, if you guys want to televise anything, we could televise it.
We'll do that.
Okay, that's great.
Keep that in mind. If you have something you want to tell the neurosurgery community, including Russia, you know, we have that Russian translation. Put the Russian translation on, see if it's any good. I'm going to put it on mine now.
Just if anyone has option to put Russian translation, yes, you can go for it.
Yeah, we'll see how accurate it is. Right now I'm speaking. You see the translation on your screen? Is that accurate, what I'm saying right now?
No, I'm not able to see. So
I don't see anything.
yes.
No? Can you see it now?
I can see.
Anastasia, can you see the translation or no? You
I
gotta
know.
you gotta go on the bottom on captions. You gotta turn the caption on. You see it at the
Caption там
bottom?
есть
Yeah,
транскрипция.
caption and then open the menu.
Мгм.
Hopefully people that don't know English well.
The translation is not perfect, John.
No.
Yeah, unfortunately.
Come on, Giza, come on. It's not perfect. Oh, really? Well, it made progress fast. I didn't expect to see this because I don't think Zoom would come out with it unless it was fairly good. They brought it out. I thought they would wait a while. I didn't expect to see it so quick.
Who is our participant? We have two more.
Okay, we've got 6 minutes. Who likes hockey? Anybody like hockey? Any of the Russians like hockey?
Of course, all Russians, they love hockey.
That's a real big sport there, right?
Yes.
My brother played hockey. He went to Russia, but he didn't play hockey there. But he played again. Well, you don't know these names. Tretiak, Karlamov. I still remember the names. They're very big names in Russian hockey. And he even went to Japan and played with some Russian hockey players.
Who, your brother?
Yeah, they play. They go a few. The good when they're at the end of their career, they go to Japan. Some hockey players from Canada, America, and Russia, Czechoslovakia. They thought my brothers were coarse animals. I don't know how you translate that. Coarse animal. How do you say coarse animal? They were animals as far as hockey players. Okay, we have a few speakers here, right?
He has come and joined. Perfect. Hello, Rifki. Okay, 8 participants.
Hi, hello.
Hello, Rifki. Hello, my dear friend. How are
Welcome.
you? Welcome.
Hi, I'm fine, thank you. Actually,
Okay,
I'm sorry that I um have a slight misunderstanding about the um misunderstanding about the time that this webinar will
Yeah,
be
that's all
start.
right.
Sorry.
It's okay. It's okay. That actually was my fault. We're supposed to
Yeah.
start at 3 p.m., but then after us, we have Binzu Chinese webinar. So
Yes, yes, okay.
yeah. Yeah, it gets a little confusing with the time zones, and
that's
sometimes the time zone changes 1 hour. So that's a big mistake sometimes. Someone's speaking Russian, or someone's writing Russian. I don't know.
just a second.
Are you speaking there? Someone's speaking Russian. I guess I am.
Just a second. Okay. So, okay. One of our speakers.
Two minutes.
One of our speakers, Ivan, who is supposed to be the first speaker from
Okay.
Piragov team, he's at work, so he probably has some work at the hospital. So he will
Okay.
be able to join after 30 minutes. So
Okay.
who would like to present first? Anastasia or Svetlana or anyone else? Let me know.
I can do it. I mean, I'm at work too. I'm on my shift actually, so I'm really
Great.
nervous. That's why I will be cold on patients.
Oh, okay. So, well, just let us know.
Yeah.
Work comes first.
Rifki, where are you? Rifki will introduce you. Mhm.
Okay, okay. Sure,
Okay.
sure.
Okay, perfect.
Yes.
But first,
Okay.
John will start, then I will
Yeah.
start, and Rifki, you will go.
Okay, okay, sure. Hello, sorry for the misunderstanding about the time that the webinar is held. Sorry.
It's
Okay,
okay.
for the first speaker, yes. For the first speaker, we will
Rifki,
have
wait, just a
our
second.
yes.
Hello.
Okay.
Just a
Okay. Hold
second.
on. Okay.
Yes.
Ready to
Hold
start,
on.
Yes, yes.
Margiza?
Yes,
You
I
ready?
think we can start.
Okay, I'm gonna take the person off the
Sure.
screen. Okay, because I need to introduce their face. Okay. I'll be introducing you first, Nargis, okay?
Okay, then.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the honor of having a fairly regular bi-monthly Russia Neurosurgery Grand Rounds. And Nargiza Sastova has put together a good lineup today. Welcome, Nargiza.
Hello, everyone. Good morning, good afternoon, and good evening. Happy New Year, first of all. It's a great pleasure to start this year with our 8th webinar. Russian Neurosurgery Grand Round became as a good, tradition on neurosurgical TV, and I'm glad that we are keep going with our presentations, speakers, and I'm glad that we are growing in our academical staff, first of all. So today we will be talking about functional neurosurgery, and first of all, let me introduce our moderators. So our first moderator is Russian moderator, Dr. Andrei Dubovoy. He is head of the head and neck department at Ilinskaya Hospital in Moscow, one of the best neurovascular, micro neurovascular surgeons in Russia. And second, our moderator, international moderator, young neurosurgeon Rifki Aulia from Indonesia, who is working currently in Jakarta and mostly working in functional department. So Rifki, you are welcome to present our first speaker. To introduce.
Hello. Can I have the screen of the presentation, please? And we are going to wait a second. We are going to have two sessions, right? About we have some about functional neurosurgery. As you know, I already introduced by my friend Nargiza. How are you? Fine?
Yes, I'm good.
Yeah. So good to hear from you again for such a long time, right? Okay. We are going to have our first presentation from Dr. Svetlana.
Yes.
Okay,
Yes.
we're going to. Okay, how are you, Dr. Svetlana? Greetings from Indonesia.
Hi, thank you for having me. Can you see my screen?
Not yet. Please, could you share your screen, please?
Yes. Okay, we are going to have our topic about neuroimaging advancement in movement disorder surgery from Dr. Svetlana Asrians. Sorry if I have some mistake of spelling your name. Dr. Svetlana Asrians will.
Yeah, that's great.
Yeah, we'll talk about.
Correctly.
Oh, thank you. Yeah, about imaging for movement disorder surgery.
Yes.
Okay. She is a consultant at Burdenko National Medical Research Center of Neurosurgery from Moscow, Russia. And please, you can start your presentation.
Thank you. Thank you for
the screen and the time is yours.
Okay. So do you see my screen now?
Yes, we can see.
Perfect.
Yes, we can.
Perfect.
So as you already mentioned, I work in Burdenko Neurosurgical Center in the functional department in Moscow, Russia, and I'm mainly focused on movement disorder surgery. So today I want to talk about imaging advances for movement disorder surgery. And precise targeting, as well as thorough preoperative assessment and postoperative management of the patients, is one of the crucial steps in the successful DBS. And the process of preoperative planning has changed a lot since the introduction of this method from pre-CT and pre-MRI era to when we could only use stereotactic atlases and microelectrorecording to indirect targeting based on low field MRI, and to these days when we have high field MRI, additional sequences, and we're moving towards connectomic DBS approach when we can use tactography and functional MRI data. So I want to talk about the most commonly used targets in functional neurosurgery for movement disorders, and I want to start with the subthalamic nucleus, which is probably one of the most commonly used targets for patients with Parkinson's disease. We can see the subthalamic nucleus even on low field MRI. And to do so, we find the line that crosses the anterior border of the red nucleus at the when it has its widest diameter, and a sensory motor part of the STN is usually located around 2 millimeters lateral to its medial border of the STN. And the main problem is in visualizing the subthalamic nucleus is identifying its lower border on MRI, which is adjacent to the superior border of substantia nigra. And that's when the introduction of new modalities such as susceptibility weight imaging really helps. As you can see in the right picture on this slide with SVI imaging, we can clearly see the border between STN and substantia nigra. And what this allows us to do is to perform a sleep DBS STN. As you know, traditionally DBS includes microelectrorecording and intraoperative testing, which allows us to verify the target and to choose potentially a trajectory with the widest therapeutic window. However, these additional techniques are associated with increased intraoperative risks. So in case the efficacy of a sleep DBS is not less than the efficacy of the awake DBS STN, it would be more beneficial to perform this surgery asleep. And if we still want to do awake DBS STN, the decreased number of performing several microelectrorecording tracks will lead to decreased number of intraoperative hemorrhages. So in order to assess efficacy of asleep and safety of asleep DBS STN in our center, we performed a randomized control trial. And the patients in the main group were operated under general anesthesia based on solely 3 Tesla MRI data and intraoperative CT. And patients in the control group were operated traditionally. They also had 3 Tesla MRI and they were operated awake using microelectrorecording and intraoperative testing. And when we analyzed the proportion of leads in the control group that were placed using non-central track, we found that it was only 10%, which is quite low. And an interesting observation was that when we analyzed the outcomes of patients whose electrodes were implanted using the non-central track, we found that 3 out of 4 patients had either stimulation-induced complications or poor motor outcome. Obviously, the number of patients is too small to make statistically significant conclusions, but we can say that microelectrorecording and intraoperative testing does not necessarily guarantee a good outcome. And talking about efficacy, patients in both groups demonstrated dramatic motor improvement, around 70% in the UPDRS-3 scores. And this could possibly be explained by specific characteristics of patients included in our study, such as relatively young age, from 45 to 65 years old, and a high levodopa response, around 70%. Also, patients in both groups demonstrated a considerable decrease in motor complications and in levodopa equivalent daily dose. And as for safety, patients didn't experience any significant intra or postoperative complications. There were 2 cases of acute psychosis and 1 case of a seroma formation in the region of neurostimulate patients in the control group. Dysarthria was the only stimulation-induced complications in our patients, and it happened in 4 cases in the main group and in 3 cases in the control group. So based on these results, we can say that direct targeting for the STN enables to perform a sleep DBS STN with very good results. And let's move to the next target, which is globus pallidus internus, which is used mostly for Parkinson's disease and for patients with dystonia. And we use the same protocol of algorithm of MRI preoperative planning for the GPI that we use for the STN. You can see that using susceptibility weight imaging with 3 Tesla MRI, you can see the lamina between globus pallidus externus and globus pallidus internus. And when we analyzed the percentage of leads that were implanted using non-central track in these patients, we found that only 3% of the electrodes were implanted using non-central track, which is a really low amount, really low proportion. And when talking about imaging advances for deep brain stimulation, I would also like to mention the fact that it not only helps us to make a preoperative planning, but it also helps us to analyze correlation between clinical outcomes and different locations of the leads. So we can find this perfect sweet spot of stimulation. And in case of globus pallidus internus, there are publications that mention that in patients with Parkinson's disease, the therapeutic contacts are actually located in the region between GPE and GPI, or even in the GPE itself rather than GPI. And when we compare the active contacts in patients with Parkinson's disease and patients with dystonia, we also found that in patients with Parkinson's disease, we mostly use higher contact levels, while in patients with dystonia, we use lower contact levels. So the active contacts of patients with Parkinson's disease actually located in the GPE and in the border between GPE and GPI, which is quite interesting too. Well, when we talk about visualizing of the STN and GPI, we can visualize the structures on MRI directly, and they also have the specific patterns of neuronal activity that can be identified during microelectrode recording. But with our next structure, this ventral intermediate nucleus of thalamus, we can't visualize this structure directly on the MRI. And that's when tractography serves as a great additional tool. And with respect to VIM, dentator thalamic tract has been shown to have a big role in the clinical outcomes. So there's a postulated theory of 3 stereotactic targets and 1 anatomic fiber tract, which means that clinical outcomes on tremor control after DBS of the VIM, the posterior subthalamic area, and even the subthalamic nucleus depends on the involvement of dentator thalamic tract. And there are several publications dedicated to a correlation between distance of the active contacts to DRT with clinical outcome on tremor control. So the lower this distance is, the greater tremor control we get after surgery. And we in Budenka also used tractography to as a tool of preoperative planning for DBS in this region, as well as lesion surgery. And here you can see a case of successful lesion surgery of VIM in patient with post-stroke trauma and post-stroke hemiembolismus. As you can see on the MRI, the center of the DOT is in the center of the lesion, and this patient has had a complete trauma suppression postoperatively. And the next case is the case of patient with trauma-dominant Parkinson's disease who had poor effect after surgery. And you can see that on the postoperative MRI, the center of the tract is located lower and posterior to the center of the lesion. So this could probably that's why the patient probably had a poor outcome after surgery. Unfortunately, sometimes we cannot explain why a patient has a poor outcome based on this data, like in this case, with a patient with trauma-dominant Parkinson's disease who had DBS of the posterior subthalamic area. And after surgery, this patient had persistence of his left-sided tremor. And you can see on this MRI that the right lead goes through the tract and the left lead located anterior to the tract. But once again, the patient had a persistence of the tremor in his left side. And if we look at the coordinates of the target and the coordinates of the leads, you can see that the right lead is located anterior to the left lead. And probably the right lead is misplaced. So this correlates with the clinical data, but does not correlate with the tractography data. And that leads us to an important question. In what cases and to what extent can we trust direct targeting? Excuse me. So obviously, we should have high quality MRI data, because sometimes retesla MRI with SVI targeting can look like this, like on these slides, due to movement artifacts and due to low iron deposition in basal ganglia in some patients, some younger patients. And with DTI, it's even more complicated, because data we get from DTI is highly variable, dependent on probabilistic versus or deterministic algorithm of DTI due to distortion and slight thickness. And negative contributors to poor data can also be fusion errors, brain shifts, stereotactic errors. So to make a conclusion of all this, I would like to say that in order to perform direct targeting, we should always have these conditions. We should have high quality MRI. And if we use DTI, we should always double check whether DTI data correlates with anatomical knowledge. Does it look realistic? Should this structure be here? Or maybe we just have a poor DTI data. We should try to minimize brain shift by minimizing pneumatofolia during the surgery. And we should always perform intraoperative confirmation of electrode location using intraoperative CT or MRI. And that's all I wanted to tell you today. Thank you for your attention.
Thank you, Dr. Svetlana. Okay. So now, are we going to have
Any questions?
discussion?
Yes, if anyone has questions or some comments from the audience or from participants.
Yeah.
Okay. Svetlana, thank you
So
very
much.
much.
Okay. So while we are waiting, I have a question for Dr. Svetlana. You mentioned about from the beginning of the presentation, you mentioned the F-gator sequence of MRI. Can you um, explain to us how often you use the F-gator and about you how often you use the F-gator and S1 for the MRI sequence, advanced MRI sequence for movement disorder surgery preparation?
Thank you for your question. No, that was based on the literature data. We don't use FGATA in our clinical practice, and unfortunately, we don't use QSM as well. So we only use SVI.
Okay, so you are only using the SVI for the preparation of the movement disorder surgery.
I mean, yeah, obviously we use T2 and T2 flare and SVI.
Yes, yes. SVI for the addition because the T2 and 2 flare is a default standard for the movement disorder surgery. Okay, nice. And also, in
Okay, poor connection.
I think you better take over, Nagisa. I think you fell off.
Okay. Dr. Andrei, would you like to present our next?
Yes. I am happy to introduce my good friend, Dr. Anastasia Kuznetsova. She is now working as a neurologist in National Medical Research Center of Neurosurgery named after Burdenko in Moscow, Russia. The topic of her presentation, the use of hemispherectomy in adult patients. Please, Anastasia.
Thank you. Good day, dear colleagues. I'm very happy to be here, and I would like to thank John and Nargiza for inviting me on this conference. 1 second. Can you
Yes.
see my screen?
Yes, we are able to see your screen. Yes.
Yes,
Okay.
we see your screen.
My topic will be about functional hemispherectomy in adults with drug-resistant epilepsy. And I'd like to present you 3 clinical cases which performed by one surgeon from Burdenko Neurosurgical Institute, Professor David Pitshilauri. In fact, this surgery is performed mostly in pediatric population. But I'd like to tell you about this method of treatment in adult group. And first case, it's a female patient, 29 years old. Her early age anamnesis was no symptoms and child development was normal. There were no cases of epilepsy in family members. First episode of focal unilateral clonic left-sided seizures presented at the age of 8. And the MRI scan showed a cyst in the right temporal lobe. In 2000, the subdural shunt surgery was performed with the removal of pathological tissue. But mild left-sided hemiparesis developed after the surgery. And later on, in 2003, the patient was diagnosed with Rasmussen syndrome. Status epilepticus occurred several times, and anti-epileptic treatment included several drugs, but all the drugs mentioned above didn't have any noticeable effect. At the time of admission, seizures were focal unilateral clonic left-sided seizures without impaired awareness occurring daily, and second type was manual and oral automatisms from 10 to 13 times a month. This patient was right-handed and in neurological status. There was no cranial nerve deficit, just mild left-sided hemiparesis, and reflexes were increased on the left side. His MRI scan showed postoperative changes in the right temporal frontal region and atrophy and gliosis of the right hemisphere and right part of the brainstem. On video EEG monitoring, regional epileptiform activity was registered in the right hemisphere, and 4 episodes of seizure were registered. It was manual and oral automatisms with transformation to bilateral tonic-clonic seizures. And seizure onset zone was in the frontal, central, parietal regions of the right hemisphere. And we decided to perform a surgery, and right-sided transsylvian functional hemispherectomy was performed in December 2018. In Burdenko Neurosurgical Institute by Professor David Pishilauri. In early postoperative period, left-sided hemiparesis increased from mild to moderate, and histology showed this embryoplastic neuroepithelial tumor. In conclusion of my first case, I want to say that completely seizure-free after surgery, and in neurologic status, hemiparesis increased from mild to moderate. Also, after 12 months after the surgery, antiepileptic drugs was discounted. And this is a story with a happy ending because this patient, 2 years after the surgery, got married, and 1 year ago, she gave birth to a healthy baby. Okay, second case. It was male patient, 27 years old. His earlier age anamnesis, no symptoms, and child development was normal. Also, there were no cases of epilepsy in family members. At the 1 year, 10 months old, patient presented with the series of unilateral clonic left-sided seizures while having fever. And in 6 months, it appeared again. But at the age of 8, clonic right-sided seizures and right-sided hemiparesis appeared. At the time of admission, seizures were focal unilateral clonic right-sided seizures with transformation to bilateral tonic-clonic seizure. And second type of seizure was behavior arrest with impaired awareness, 10 times a month. And the MRI scan showed hemiatrophic changes of the left hemisphere with a mesial complex. This patient was left-handed. In neurological status, there was no cranial nerve deficit, but just moderate right-sided hemiparesis, and reflexes were increased on the right side. On video EEG monitoring, regional epileptiform activity was registered in left hemisphere in form of single spikes and spike wave complexes. 2 seizures were registered, and the seizures developed as follows. Behavior arrest, then eye version to the right side. After that, manual and oral automatisms in the left hand, and further focal unilateral clonic right-sided seizure. On EEG, we saw diffuse theta discharges, and we didn't see seizure onset zone, but the semiology of seizures indicates a seizure onset zone from the left hemisphere. And we performed a VADA test, which showed that the speech function is localized in the right hemisphere. And we decided to perform surgery, and left-sided transsylvian functional hemispherectomy was performed in October 2018. There were no changes in neurological status. But unfortunately, after 3 months after the surgery, there was 1 focal unilateral clonic right-sided seizure. And in 6 months, it appeared again. The MRI scan showed that there were connections between the hemispheres in the area of the posterior forceps. And on video EEG monitoring, regional epileptiform activity was registered in the left hemisphere of the brain in the form of single spikes and spike wave complexes. And we performed dissection of the splenium of corpus callosum. After that, this patient was completely seizure-free. And concluding my second case, I'd like to say that this patient have seizure outcome angel 1A, and 12 months after surgery, antiepileptic drugs were discontinued. And there were no changes in neurological status after the surgery. Okay, and third case, this is a patient, male patient, 37 years old. The patient was born at 32 weeks of gestation, and at the age 8 months, he had a stroke and developed right-sided hemiparesis. He started working at the age of 3, and there were no cases of epilepsy in family members. At the 13 years old, bilateral tonic-clonic seizure were started. Seizure frequency was once, twice a month. Also, non-motor and motor unilateral right-sided seizures appeared. His antiepileptic treatment included carbamazepine, gabapentin, and valproic acid. At the time of admission, seizures were focal non-motor unilateral right-sided seizures occurring daily and focal unilateral clonic right-sided seizures with transformation to bilateral tonic-clonic seizures 20 times a month. MRI scan showed that consequences of stroke in the left temporal and parietal lobes of the brain. This patient was left-handed. In neurological status, the face is asymmetrical on the right side, and he had moderate right-sided hemiparesis. Reflexes were increased on the right side, and he had hypotrophy and shortening of the right leg. On video EEG monitoring, in waking and sleeping, epileptiform activity was registered in the form of spike wave complexes in the left temporal and frontal central regions. We registered 3 clinical episodes. There were focal unilateral clonic right-sided seizures. And on EEG, seizure answer zone was in the left frontal region. Also, we performed WADA test, which showed the speech function is localized in the right hemisphere of the brain. And left-sided transitive functional hemispherectomy was performed in February 2018. And in my third cases, we achieved seizure-free status for this patient, and 10 months after surgery, antiepileptic drugs were discontinued. There were no changes in neurological status after the surgery. To sum up the results of all cases, I'd like to say that Transylvanian functional hemispherectomy was performed in 3 patients, and the follow-up period ranged from 10 months to 6 years. The seizure outcomes in all 3 patients evaluated on the Angel scale is 1-8. All patients completely seizure-free. In one of the patients, hemiparesis increased from mild to moderate, and 3 and other 2 had negative dynamics. All patients could move on their own after the surgery, and none of the patients had speech impairment. To conclude, functional hemispherectomy can be a highly effective surgical treatment for hemispheric epilepsy in the presence of drug-resistant epilepsy, severe hemisphere brain lesion, and hemiparesis. This is our epileptology team of Burdenko Neurosurgical Center, and I think that such difficult clinical cases should be managed by established teamwork. Thank you for your attention, and thank you to my colleagues.
Thank you, Anastasia, for your brilliant presentation. Any questions from audience?
Can I ask a question?
Yes.
Yes, thanks. Please ask your question.
I'm Dr. Ravi Monroe from Bangalore. Thank you for having me here. A very good presentation, Dr. Anastasia. The Rasmussen's disease, which you showed as the first case, what we usually see is progressive atrophy with atrophy of the caudate occurring over many years with epilepsia partialis continua, either involving the tongue or the hand. Was it the same? I did not fully understand the semiology which you said. Was there EPCs? And there was a subdural rather than progressive atrophy. Would you care to remark about this?
I think this patient didn't have progressive atrophy. This diagnosis was this diagnosis he get a lot of years ago, and his MRI scan was without dynamics, without negative dynamics, and I think his atrophy hadn't negative dynamics.
So it was not progressing, you mean?
Yes.
And the diagnosis of Rasmussen's was established by biopsy or by some other means?
I think that he didn't have this diagnosis because his histology didn't show it, and clinical picture didn't show it. Because this diagnosis was in his child.
Okay. So was it any biopsy done during the childhood?
Yes, was.
Was the biopsy done, and biopsy did not show?
Yes.
Okay.
His biopsy showed desembroplastic neuroepithelial tumor.
Oh, okay. So it's not Rasmussen's.
Yes, I think yes.
Okay.
Done.
Other questions? Other questions?
Comments or questions?
Or comments? Okay. Thank you, Anastasia.
Thank
Yes,
you.
also I would like to give a few comments. Anastasia Kuznetsova is our first doctor who is not neurosurgeon today. So we slowly started inviting additional neurosurgical fields. So our first neurologist, and you have done a great job as my colleague, as my friend. And thank you so much. And first of all, thank you to Burdenko Institute. Finally, we got exception from Burdenko Institute to get speakers and participants. So I hope we will continue with the same speed.
Fantastic.
I would like to present our next speaker, Dr. Ravi Mohan Rao, neurosurgeon, one of the best neurosurgeons from Bangalore. Dr. Mohan Rao is MCH, DNB, MS. Dr. Mohan Rao was working in Sri Chitra Hospital over 10 years. Sri Chitra considered one of the best institutes in India. Right now, he is the head of the department Bangalore Apollo Corporate Hospitals in Sheshadripuram. The major interest of Dr. Mohan Rao is cerebrovascular surgery, epilepsy surgery, functional, skull-based cranial endoscopy, and stereotaxic neurosurgery. In epilepsy surgery, he has done more than 300 epilepsy surgeries. And apart from that, he has been done SEEG for evaluation for complex epilepsy patients. And today, we would like, sir, could you share your screen, please?
Yeah, is my screen visible?
Yes, screen is visible, and today Dr. Mohan Rao will be talking about scope of epilepsy surgery in medially refractory epilepsy. Thank you.
Thank you very much, Dr. Nagiza. Thank you very much for inviting me to give a talk in this esteemed meeting. Russia has been a very close and valued and trusted friend of India for many decades now. And I'm very honored and delighted to be here presenting our experience, a little snapshot of our experience in epilepsy surgery. This is my team. At the extreme right and left are my two senior epileptologists, Dr. Dinesh Naik and Dr. Sujit Kumar, who do all the workup of our epilepsy surgery patients. Some of them are my neurosurgery colleagues, anesthesia, neurotechnicians, etc., neuroradiologist, Dr. Sharath. This is our experience in the corporate sector from 2010. We have done 465 epilepsy patients, 229 are pediatric, 236 adult, 42 hemispherotomies since there were cases presented today. And we use Diller-Landis transvertex hemispherotomies. I have also done 2 Willemeus, which were shown today. What I would like to show, apart from what was shown as hemispherotomy, is motor sparing subtotal hemispherotomy today. And also talk a little bit about surgery on the motor cortex, surgery around the language areas, and hypothalamic hamartoma if time permits. So going straight away to motor preserving subtotal hemispherotomy, we have done about 9 patients who have undergone subtotal hemispherotomies. The criteria being there is a preserved Spencer grip in the patient with a hemispheric disease causing medically refractory epilepsy. So this is a 14-year-old boy. Clinical diagnosis was complex Passer seizures extratemporal of right hemispheric origin. Pre-op Engel score was 9, and PET showed a right hemispheric hypometabolism. Left side was normal. In hemispheric pathologies, we use PET also to rule out presence of any abnormalities on the so-called normal hemisphere, which could be a prognostic indicator apart from incomplete hemispherotomies done. So this is the scan, MRI scan, which showed cortical lamina necrosis involving the entire hemisphere, but sparing the motor cortex. You can see that the motor cortex is spared, and this patient had intact pincer grip. He could catch a ball with his hand, with his right hand, left hand. So the hand function was fairly well preserved. And we thought a complete hemispherotomy would result in loss of his hand function. This is the intraoperative stimulation after exposure of the brain.
Okay, that's enough. That's stop.
Identified the motor cortex. And what we did was preserve the central cortex, motor sensory cortex, attached to the brainstem, did a frontal lobe disconnection, and a posterior quadrant disconnection, which is disconnection of the temporal, parieto-occipital lobes, leaving the central cortex intact. This was done in 2011. And post-op, his seizures have stopped. He had psychosis, which have stopped. Antipsychotics have been stopped. His grip is quite good. Transfer of objects is quite good. And that served the purpose of preserving his hand function, at the same time eliminating the refractory epilepsy. Now I come to operations on the motor cortex. Direct surgery on the motor cortex, we have done about 6. This is a 31-year-old patient who presented with sensory. Oh my God, what happened? Who presented with tinkling sensation and the feeling of tightness in his right hand. And the arm raises above the head. If standing, he tends to fall backwards. If prolonged for more than 1 minute, postictal weakness of the right hand for a few minutes comes. Sometimes he's unable to speak for some time without any jerk. He gets around 1 to 2 seizures per day, sometimes more. Maximum seizure-free period was for 5 months. His neurology otherwise was normal, resistant to every possible anti-seizure medication. Though he has studied and completed his degree, but he has not been able to do any business, frustrated and depressed. So the clinical formulation was left hemispheric focal seizure with impaired awareness, extratemporal, frontoparietal in location. This is the EEG, which showed interrectal epileptiform discharges in the C3AV, P3AV on the left side. This is the ictal semiology. It shows the raising and extension of the right arm, raising and flexion of the left forearm. These seizures are quite disabling because he falls down if he's standing. And this is the ictal EEG, which again shows these spikes going on to these seizure discharges with artifacts and flattening of the waves in the left frontocentral region. This, we label it as the Statue of Liberty sign, with the right hand being raised and the left hand being flexed. So our hypothesis was drug-resistant focal epilepsy syndrome, left hemispheric, both sensory and motor, but no clonic at the beginning of the seizure, no Jacksonian march. So we hypothesized that this kind of elementary motor seizure can arise from the premotor area, SSMA, precuneus, mid-cingulate, and insula. This is the MRI scan, which was passed off as normal for several years in various centers. However, when we reviewed it, it showed that there was a depth of sulcus dysplasia. This is the motor cortex, sensory cortex. Depth of sulcus dysplasia involving the anterior bank of the motor cortex and the premotor region, which is seen clearly here. This is the motor cortex, the anterior bank and the depth of the sulcus adjoining the motor cortex is involved. And this is the T1 weighted image showing the same dysplasia. The PET showing the hypermetabolism corresponding to that. So these are the MRIs which were done in 2009, 2016, which were passed off as normal. A PET MR fusion, no discrete lesion was found. And the MEG localized it to the opposite hemisphere. So there were a lot of confusing signs in this patient apart from being labeled as a patient with normal MRI. So we took him up for stereo EEG in order to prove that the seizures are coming from here in the view of so many contradictory reports. This was the plan, which planned to sample the motor, sensory, the insula, and the parietal lobe in this patient. And this is the location of the electrode in the region of the suspected dysplasia. And this is the habitual seizure, which came in the stereo EEG, which went on to develop into a bilateral tonic-clonic. And this is the stereo EEG. This is all the electrodes being seen. I will concentrate on the lesion posterior. Electrode were lesion inferior, lesion anterior, lesion posterior, inferior frontal gyrus, etc. The previous one being all others, not showing any ictal activity. And stimulation of the lesion posterior electrode, contacts 3 and 4, elicited the seizure. So there's a stimulated seizure. And the stimulation at 2 milliamperes, you have a post-potentiation, stimulation potentiation with the seizure being recorded. This is the intraoperative, this is the motor cortex, and this is the sulcus premotor region, depth electrodes inserted during surgery. This is the sulcus, which houses the depth of sulcus dysplasia coming onto the anterior bank of the motor cortex. This is the motor cortex. So the motor cortex, wrist area, the thumb area. The thumb area. Where the contraction was elicited at 2-3 million. So the lesion is just anterior to the vein. Lesion is anterior to the vein, probably this. Maybe the so the bulk of the lesion is in front of the sulcus, but there is a component attached to the motor cortex, anterior bank of the motor cortex at the depth. The sulcus is the lesion here. Yeah, thumbs up. And this is the video of the surgery. This is the motor cortex, the thumb area, the wrist area. I'll fast forward it in interest of time. You see the subpial resection being done. This is the arachnoid pia of the anterior bank of the motor cortex. And the dysplasia was removed. What I thought was the remainder of the dysplasia, this very firm, rubbery. I could chase it till the depth of the sulcus. Their stimulation started yielding motor responses. And in order to spare his hand function, I was a little conservative here. Post-operative stimulation yielded all the responses. But then probably there is a residual dysplasia. This is the anterior bank of the motor cortex. There is a residual dysplasia there. And this is the ECOG during surgery with depth electrodes, which showed the spikes. Anterior, there is no spikes. But posterior to the lesion at the inferior margin, some spikes were residual. And this is the post-op MRI, which shows probably this part of the dysplasia is left behind. This was a type 2B dysplasia. And 6 months he was seizure-free, then gradual ramping up with recurrence of the same seizures happened, which is expected when you leave behind part of a dysplasia. So this is the dysplasia which is left behind. We had to take him up for resurgery. And according to this paper, all the pyramidal cells which give rise to the corticospinal tracts are predominantly in the posterior bank. And in the anterior bank, you don't have that many pyramidal neurons. As a result of this theoretical concept and also demonstration of the pyramidal cells, it's possible to resect the anterior bank without causing a permanent neurological deficit. So that's what we did in surgery. This is the motor cortex anterior bank. This is the residual dysplasia. So that's the anterior bank, posterior bank, and the dysplasia. We went ahead resecting part of the anterior bank of the motor cortex in order to get hold of the dysplasia at the depth of the sulcus there. And this is the excision of the dysplasia post-resection stimulation. And the recording at the beginning, post-resection, the strip recording showing no persistence of spikes. And this is the post-op MRI merger on the stealth station with the pre-op and the post-op showed that the whole dysplasia has been removed. He, however, developed 1 week later after surgery, initially had no deficits. He developed hyponatremia-induced seizures due to carbamazepine, which was stopped. When these seizures appeared, he developed hand weakness. And then at 3 months follow-up, he's completely normal. His seizures have stopped. Hand function has returned back to complete normality. Grip is normal. Fluency of motor movements is very good. Speech is normal. Walking is normal. The second case where we operated on, which I want to show, is tongue area focal cortical dysplasia. This is the thumb knob, and this is the tongue area, which resulted in the patient having EPCs of the tongue, which was extremely disturbing and not allowing him to work. And this is the ECOG from the motor cortex showing the spikes. I'll rush through these slides. Post-resection, tongue and jaw area, this is the ECOG, the motor assessment. This is an awake craniotomy with motor and speech mapping, though it's on the right side. So we use the EPCs to monitor whether the resection is adequate apart from the ECOG. And there was no language disturbance except for dysarthria due to stimulation of the tongue and the jaw area. This was normal. Stimulation start. And this is the post-op. He required a serial excision of the lower homunculus of the motor cortex below the hand area to completely eliminate the spikes and the EPC going up to the face area. And post-op, he had an initial transient hemiparesis, which improved completely. His speech became normal. His EPCs have stopped. Though on stopping the drugs, tapering and stopping, he had seizures. So the anticonvulsants had to be restarted. So he had continuous seizures, which are stopped now. Now I come to language area. 2 cases of language area I want to show. I have time now, Nagisa.
Yes, sir, you can continue. We do have time.
Thank you. This is an anterior language area, 16-year-old girl with this depth of sulcus dysplasia again in the junction between the middle and inferior frontal gyrus, an anterior language area. The PET showed the hypermetabolism, and this is the fMRI, which shows possible function at the mouth of the sulcus, leading to the dysplasia. And we did a stereo EEG both for brain mapping, knowing which part of the dysplasia is giving rise to seizures, and also to tell the patient about possibility of speech disturbance. So this is the stereo EEG map. And ictal onset was from the anterior margin of the lesion, contacts 5 and 6, stimulation of 1 and 2 of the inferior margin of the lesion electrode also yielded seizure, and stimulation of the speech electrodes, speech area electrodes of the pars opercularis and pars triangularis produced speech arrest. This was an awake craniotomy. Okay. Count 1 to 100. And this is the language map, Sylvian Fisher, temporal lobe, frontal lobe. This is the language map of the inferior frontal gyrus, angular gyrus, and posterior superior temporal gyrus. And this is after the excision of the depth of sulcus dysplasia, sparing the language. This is the pre-op and the post-op. And 2 years, she is Engel 1 off drugs, FCD type 2B, so completely seizure-free. Pre-op, she used to get multiple daily seizures. Post-op, she had transient dysphagia and speech apraxia lasting for 2 to 3 months with extensive speech physiotherapy leading to complete recovery. She completed her 12th exams in 2017. So an operation on the posterior language area. Anterior language area may be more forgiving, but posterior language area may result in dense speech deficits, which impair the language of the patient. 11-year-old female. Episodes consist of the patient holding her right ear due to pain, appears frightened, crying and calling out for her parents, and remains responsive during the episodes. So the formulation was, it could be from the Heschel's gyri, lateral temporal cortex, posterior language, posterior insula, frontal operculum, and the inferior parietal lobule, which is the posterior language areas of angular and supramarginal gyri. This is a spontaneous event. She gets that pain in the ear, which indicates. And even her MRI was thought to be normal. However, there was a dysplasia, which we realized on very close scrutiny of the MRI, which showed a depth of sulcus dysplasia. This is the inferior parietal lobule. This is the STG. So this is the Sylvian fissure. So you have on the lower bank of the Sylvian fissure, the dysplasia, and the upper bank of the Sylvian fissure in the dysplasia, which is seen in this MRI too. And this patient also had a stereo EEG for language mapping and confirming the location of the seizures. I'll skip to the slides. And what we did was approaching it. Instead of this video, I'll explain what I did in a still picture. This is the frontal lobe, the temporal lobe. This is the entry of the stereo EEG. This is the entry of the stereo EEG electrode, which showed language area. One more electrode here showed language area. So between these two areas, the dysplasia was located at the depth of the Sylvian fissure, reaching up to the posterior insula. We went along the bank of the Sylvian fissure, removing the cortex so that the dysplasia gets denuded and shaved off. And this is the post-op, including the posterior and superior insula. The dysplasia along the Sylvian fissure has been excised. And post-op, seizure-free.
What is your father name?
With a totally normal speech.
What is your mother
So
name?
we had to operate between two language areas identified by stereo EEG to remove this dysplasia. Because we went along the banks of the Sylvian fissure, we didn't do any white matter disconnection, which connects the temporal and frontal language areas. Can I show this? Or
Yes, you can show so.
Thank you so much. I'm sorry if I'm exceeding my time.
No, it's okay.
Treatment options for hypothalamic hamartomas include RF laser ablation, focused radiotherapy, microsurgery, both microsurgery and endoscopic resection. So these are the options. You can add highly focused ultrasound, high intensity ultrasound to this list. So the first case is a 3-year-old child who presented with gelastic seizures, 3 months with occasional generalization, up to 5 seizures per day with cognitive decline, not walking properly because of the frequent seizures. This is the hypothalamic hamartoma, sessile hypothalamic hamartoma. It's attached to the left side of the hypothalamus and going up to the floor. All the seizures spread through this connection, and there is no connection here to the opposite side. So what we need to do is disconnect this completely from the hypothalamus on the left side. This is a fairly black seizure. This is the EEG which shows temporal spikes. That is only to be expected in hypothalamic hematomas, unless you put a depth electrode directly into the hematoma for recording. And we did the midline transcallosal approach. There were bridging veins which had to be freed. And this is a corpus callosum which is being incised in the midline. There is a marker of the midline which can be seen. Neuronavigation was also used. And then as you deepen in the midline, these are the two fornices which appear just above the velum interpostum. We need to be strictly in the midline and enter the cavum septum pellucidum. This is the cavum septum pellucidum, the two septi of the two leaves of the septum pellucidum. This gets developed very easily when there is a cavum. With a dissector, we can develop this plane. See the velum interpositum of the roof of the third ventricle. And then we see the hypothalamic hematoma, choroid plexus in the roof of the third ventricle, the interthalamic adhesion, a depth electrode recording, and then we start piecemeal resection. And the aim is to disconnect it from the side where it's attached. So it's not necessary to completely remove the hematoma, but it's most essential that we disconnect it from the site of attachment completely. These are the intra-op recordings from the hematoma. And then removal, we see the interpeduncular fossa cistern. And then the branches of the PCA, bacilla perforators. And this is the arachnoid of the interpeduncular cistern. This is the pathology report, the post-op MRI. Some residual bits may be seen, but they are all disconnected, hopefully from the wall of the hypothalamus where it's attached. And this is the T1 image, post-op MRI. It's showing that the floor of the third ventricle is perforated into the interpeduncular fossa. And post-op.
How are you? How are you?
He has no deficits.
He's talking.
Doing well.
Now
he started walking, occasionally smiles, cognitively improving, no falls, drops, or secondary generalized seizures. AD is reduced significantly. Now, another approach which I use sometimes is a contralateral translamina terminalis approach to the hypothalamic hematoma. This is a hypothalamic hematoma. This is the video it is showing the gelastic seizures going on to secondary generalization. She smiles, which is much less. So it becomes secondarily generalized. This is the contralateral approach, the A1, lamina terminalis, optic chiasm. The lamina terminalis has been opened. And then you see the hematoma. This is the hematoma. This is the wall where it's attached, which can be seen. This approach can be used only in anteriorly placed hypothalamic hematomas. Posteriorly placed, it would be a mistake to use this approach because you can't see the posterior aspect as it's limited by the anterior cerebral artery. And the depth electrode recording, the excision is completed. This is after the excision, complete excision of the hypothalamic hematoma through the lamina terminalis. Contralateral approach, the post-op CT. The patient did very well. Pre-op 10 to 12 seizures per day, no seizures.
very good, Amma. Thank you.
Doing well neurologically.
ಚೆನ್ನಾಗಿ ಮೇಲೆ ಹಲ್ತು ಎಷ್ಟನೇ ಸ್ಕೂಲ್ಗೆ ಹೋಗ್ತಿರೋದು ನೀನು ಯಾವ ಕ್ಲಾಸ್ ಸ್ಕೂಲ್ ಹೆಸರೇನು
Now, the last one or two cases I want to show is failure of radiosurgery followed by what do we do next in a hypothalamic hamartoma. This was given radiosurgery in Mumbai. The patient didn't have any result from the radiosurgery, continued to have seizures. I initially used the anterior lamina terminalis approach, but there is a posterior residual. So that is the problem with lamina terminalis approach. You can't see completely posteriorly. Then I used a transcallosal interpharyngeal velum interpositum approach to try and attempt to remove the rest of the lesion. But then again, there was a small residual which led to recurrence of seizures. So what do we know? The gamma knife has been given once, surgery operated twice, a residual lesion still present at the posterior end of the hypothalamus. What I decided to do was a radiofrequency ablation of the remainder of the hypothalamic hamartoma. This is the post-op image which is seen. This was done about 3 months ago. So we have to still wait and see whether there is a long-lasting relief or whether there are still abnormal lesions along this border which may cause recurrence of the seizures. So all the modalities were used in this patient: radiosurgery, microsurgery, RF ablation. So we have to wait and see what happens in the long term. And this is the post-op. He had a steroid-induced femoral head problem. He is limping as a result of that, but he has no neurological deficits. The last case, I want to show sensory cortex seizures, which comes from the right little finger shaking, followed by electric shock-like sensation from right wrist spreading upwards till the elbow, and he feels his eyes drift upwards. The right arm suddenly drops, he loses balance and falls down. This is focal slowing, which is seen in the frontocentral leads, F3, C2, C3, P3. IEDs, shock waves. Event onset shows low voltage fast activity seen here in the C3, P3 electrode. This is the ictal event. So he starts getting that abnormal sensation in the hand. Again, here he had an occipital lesion in the MRI. He had a posterior parietal lesion. And if you look at the sensory cortex, it's thinned abnormally. So he has so many lesions, whether the entire, this on the left side, whether the entire parieto-occipital lobe has to be tackled or a small portion of the lobe. When you want to do sublobar localization, the only way to go ahead and do that is with a stereo EG. We did a stereo EG with this plan. So when you insert it orthogonally from laterally, you go through the hand sensory area and end up in the leg motor area medially. So medial lateromedial coverage. Similarly, when you go through the hand motor, you end up in the posterior SMA medially. And the seizures were coming from the hand sensory area. So there was a very focal onset, which was treated by radiofrequency ablation. So far, the patient is seizure-free, but you can never tell because there are a lot of other anatomical substrates, which, if they are part of the network, may require a much more wider approach rather than this minimally approach to control the seizures. So follow-up only will give the answer. This was done about 4 months ago. So far, he is seizure-free. But we have seen in dysplasias and lesions like this, when you incompletely remove the network, they may be seizure-free for 6 months, 1 year, and subsequently have a recurrence. So operations on the eloquent cortex is feasible and safe, requires team approach, careful analysis and planning, proper execution. Here I name only 3 people. Neurologist is the playmaker, radiologist is the midfielder, and neurosurgeon is the striker. And you need a perfect coordination between all the 3. and several other people like technicians, neurophysiologists, etc., to get a good result. So thank you very much. Thank you for your patience. I'm very sorry if I've exceeded the time. Thanks a lot.
Thank you very much, sir, for the brilliant presentation. I personally got a lot of information for myself, and I'm glad that you shared all your experiences with us. Yes, teamwork is the most important, I think, most important thing in order to be successful, especially in epilepsy surgery. Any questions from the audience? Yes, we do have questions. Just a second. From Dr. Antonina Kozlova. So the question is regarding the first case. Why didn't you use direct intraoperative stimulation by handle electrode? It would be more free in space of craniotomy. So that is the question.
I'm trying to remember which is the first case now.
Your first surgery.
Case, I'll just
Mm-hmm.
see which one is the first case.
And also in our panelists today, we have Dr. Mario Ganau from Oxford Institute. So if Dr. Mario would like to give comments.
Italy, yeah. Yeah, so what is the question?
So the question, why didn't you use direct intraoperative stimulation by handle electrode? It would be more free in space of craniotomy.
Intraoperative stimulation.
Yes, by handle electrode.
Is the question asking why did we do stereo EG and should have gone to direct surgery?
Yes.
The question?
Yes,
if
yes.
I understand it correctly.
Yes, sir. So
see here the problem was this patient had done the rounds of several epilepsy teams in India, including NIMANS and other places where MRI was labeled as normal and PET didn't show any abnormality according to the PET done earlier, and also MEG showed a contralateral localization. So this patient was very skeptical, and we had to explain that if you need direct proof, we can sample the lesion rather than proceeding directly. So that was the logic with which we did the stereo EG to confirm that this is the one causing the seizures. And yes, so as you get more experience operating on these motor cortex lesions, I'm very sure that the suggestion is well taken. You can go directly when you visualize the lesion. So initially you have to visualize the lesion and then drop a proper plan. And this experience has given us valuable inputs onto how to tackle this lesion. In fact, in one case where the motor cortex was directly involved, we had to resect the hand area. That was another valuable experience. It's a strict no to resect the hand area. But then the patient was so desperate, a female patient, young patient, wanted to get rid of the seizures desperately. We had to do an awake surgery. During surgery, the spikes kept coming and did not disappear. The EPC did not disappear till we resected the hand area. And we use this technique also in the tongue area. But the problem in tongue area is the recovery is full, whereas in the hand area, recovery is incomplete. In spite of extensive counseling, that patient said she doesn't mind the hand weakness, but wants the seizures to stop. So that's why we had to go with this plan. I hope that answers the question.
Yes, I also hope so. Thank you. Amazing video in operative room. High quality testing. Yes. Any other comments and questions from the audience? Okay. Thank you so much, sir. I think we can move to our next speaker.
Thank you very much.
Okay. Rifki, would you like to introduce?
Yes.
Yeah.
Thank you, Nargisa, for giving me back my session. And sorry for the inconvenience for the interrupted connection of mine. Okay, now do we have Dr. Bakhtiar on board?
Yeah, Hi.
Hi, hello, sir. How are you?
Yeah, good. Thank you.
Yeah, sure, good. Okay, so
Today is weekend, so I am with kids.
yes, I saw your kids there on screen with us. Okay, so can you start your screen
Yep.
sharing? So
Where was?
Dr. Bakhtiar Mohammed Daminov. Sorry if
Yes.
I miss spell of your name.
Yeah.
Okay, so Dr. Bakhtiar working from for nanomedical clinic from Tashkent, Uzbekistan, right?
Yes.
And his talk is going to be interesting for me because he will talk about first vagus nerve stimulation implantation in throughout your country in Uzbekistan.
Yes.
Am I right?
Yes.
Okay, sure.
Yes. You're right.
I would
Okay.
like to say a few words as well. So, Dr. Bakhtiar Mohammed Aminov is from my home country, the first person from Uzbekistan who is presenting on Russian neurosurgery grand rounds today, and he's
Nice to know it.
in Max Hospital in India, was trained in China, in Nagoya Medical Center in Japan, and in Alvadora Hospital in USA. So he's a member of American Association of Neurosurgical Surgeons, Parkinson Disease Association, and International Neuromodulation Society. So, Dr. Bakhtiar, you're most welcome.
Okay, thank you. So, comparing to my colleague, my presentation will be super short and super fast. So, it's first VNS installation in Uzbekistan. So our case is it's a 25 years old male. He's a 22. He has a 22 years of epilepsy anamnesis. He has a history of meningoencephalitis. Diagnosis is focal right temporal epilepsy, structural etiology with focal automotor seizures, and loss of consciousness. Pharmacological resistant. So the code is G40.2. So diagnosis was confirmed by two international trained epileptologists. Before surgery, his daily medications is lamotrigine 200 milligrams, valproate acid 2000 milligrams, and topiramate 200 milligrams. So it's his MRI. And I can show you the whole sequences if you're interested. So 1 second. So can you see it?
Yes, we can see it.
Yes.
You can see the same slide.
Yeah, sorry, I want to just take it. So it's his MRI. You can see everything.
Maybe it will be better if you full screen the slide, perhaps.
Yeah, put it on presentation mode.
Presentation. Okay,
Yes.
sorry guys.
Please.
Slideshow.
Okay, sorry guys. So it's his MRI. So what we have done is, so in the 17th of June of 2023, he was performed by VNS implantation surgery to the left vagus nerve. So during surgery, we found abnormal duplication of the jugular vein. It's a little bit inconvenience, but it's not so hard. So after 4 days, he was discharged from hospital. 4th of July, VNS was switched on. So we put maybe you heard it or not, there is a company called Rishena. It's a Chinese-based company. They're also producing the VNS. So it's called Mod 201A. This is how it looks in the post-op X-ray. So the electrodes are in the vagus. So by the time of presenting today, so VNS parameters were, so amplitude it's 1.0 milliamperes, the pulse size is 250, frequency is 30 hertz, pulse on time is 30 seconds, pulse off time is 5 minutes. So patient and his mother admitted epilepsy frequency reduction, also cognitive and mood improvement. No, by their word, he has been improving something like 20, 25%. He's under control of the epileptologist now. In 12 months, we will publish the further clinic data. Also, one interesting thing, this VNS, Roshena, you can program it distant with the distance. So you just need a Wi-Fi connection, so patient could be 1,000 kilometers away, and you can program it from another city. So I think it's a good thing. So Uzbekistan is a big. The patients live 800 kilometers away from Tashkent, from capital city, and the epileptologist now doing the programming from this far distance. I think this is the end of my presentation. Thank you for listening me. If you have any questions, I will be happy to answer.
Okay, Dr. Bakhtiar, thank you for your presentation. Is there any question from the Oh, I
Audience.
believe there is one from Professor
Yes.
Mario Gano.
Yes,
Mario.
just wanted to check from a ethical perspective in terms of making sure we preserve the privacy of patient. Which concern do you have regarding being able to change setting for such a wide distance and the possibility of hacking?
The company says by their document that everything is encrypted. Is it correct word? I think encrypted. So no, there is no way to hack them. And I think why somebody wants to hack VNS. So why they need it to hack? It's not a banking account.
Because the problem about that was actually initially considered when the vice president in the US had an implant which could have been hacked from outside, and this would have obviously jeopardized national security in the US. It's the first time when the discussion about hacking medical devices became public. And as far as I know, I mean, with my hat of the EANS chair of Ethical Legal Committee, this is still a matter of debate in the international community. I do not think that the companies can still at the moment provide, the level of security to prevent professional hacking. Obviously, this will not affect the vast majority of patients because there is no interest in doing so. But for index person, it's a completely different ballgame.
Yes, I understand, but we have to take also the geographical moment. So maybe
I see what you're
Europe,
saying.
in USA, you have a lot of epileptologists, but in Uzbekistan, we have only 3 epileptologists. They all live in Tashkent.
I'm not criticizing at all. Just that's the reason why my question was just around the ethical aspects of programming from outside. I see your pros, certainly, but there are many unanswered questions on this, and I think we just have to point them out.
Yes, of course. But general, we have to help the patients best we can. So I cannot ask patients come 1,000 kilometers every week just for programming.
But do you agree that this is a problem?
Yes, of course, it's a problem.
That's it. That's the message that I wanted to pass.
Yes, thank you. It's interesting.
Excuse me. Is that also is there a problem with regulation getting the device approved if it can be hacked? Do they kind of regulate that, Mario? Do you know?
Yes. So basically, for instance, in the US, there were some laws that were passed during the Bush administration because of that. Yeah.
Okay. Thank you.
Okay. Any other questions?
I have one question for Bakhtiar. Bakhtiar, thank you for your presentation. My question about the VNS device implanted by you. Does this device have a rechargeable battery, or the battery need to be replaced after a few years of exploitation?
This particular battery does not have a rechargeable part. We put this VNS for some, if you agree with me or not, for a first step of his surgery for palliative For after we told to the patient and his mother, maybe after a few years, when your epilepsies will be focused in one part of your brain, we can do the second bigger surgery, resection surgery.
Okay, I understand you. Thank you so much. Thank you.
Thank you. Thank you.
Okay. For me, this is a very interesting talk because in my country, Indonesia, actually, last month we had our first and second VNS implantation also in our capital city, Jakarta, and second biggest city in Indonesia, Surabaya. So this talk is really relevant with my country as well. And can you share to us about how is your obstacles to implement this method therapy of VNS in your country? Is there any really big obstacles or how you handle it?
Biggest obstacle is of course the price of VNS. So unfortunately, in Uzbekistan, we don't have insurance for covering it. So we have some foundations that can help it, or some patients have to pay themselves for the VNS. But starting this year, 2024, Uzbekistan is starting to do the national insurance healthcare program. So I hope in near future, maybe 5 or 10 years, it could be covered by the insurance company. So it will be better for patients.
Okay, Steve.
May I ask a question?
Yes, sir.
Okay, please, Dr. Rafi Mohana.
In our country, we have been doing VNS since 2010-11 and at Sri Chitra specifically. And we have found that VNS results are disappointing. Only 25 to 30% of patients respond. Majority don't respond or don't get a significant seizure reduction. In multifocal epilepsy and Lennox-Gastaut syndrome, we prefer to do total commissurotomy, which includes total callosotomy, sectioning the anterior commissure and the hippocampal commissure, like in the approach which we showed for the hypothalamic hamartoma. Almost 100% of them have complete elimination of drop attacks, and majority have a seizure reduction too. In this regard, I would like to ask the panelists what is their experience regarding total callosotomy. Would you use it, or would you prefer doing only a VNS?
Dr. Bacher?
It's for me or for colleagues?
Everyone, everyone, you also.
Everyone. I'm first, yes. So, as you say, the team, we have team is the more important. So I have a team for with two epileptologists. So these guys told me you have to put VNS. So I just do what they said.
Okay.
I was just a technician guy. They
Okay.
said me something, I do it.
Okay.
I'll just bring the view from the UK as well. Certainly, we would not do a total callosotomy. VNS is a much favored approach, and the number of a major surgery, including disconnection for Rasmussen, is dropping significantly. So the last time I was involved in this type of surgery, I think would have been 7 years ago. We do not do that often.
The reason being?
Reason is that they are very complex to handle, even in major centers. Every surgical intervention that we do functionally needs to be discussed on a national MDT.
Okay.
And so there are multiple views, and what is prioritized is the safety of the patient. If a surgical intervention is perceived to be too aggressive, or if there are too many surgical risks associated to it, we prefer to go for a much more standardized approach. VNS is something that we do on a regular basis. You can fit 3 or 4 patients in a conventional list.
Understood. So it's a minimally invasive approach. Agreed. But what about the results? Do you think if you take 100 patients, how many of them respond to VNS?
Oh, yes, this is a different matter. And I agree with you. And plus, you are comparing some surgical intervention that might be a definitive cure versus something that will require patient to return regularly for setting battery changes, clinical assessment, and so on and so forth. I see your view. It's just that this is the what I can see is the adopted protocol and standard operating procedures here in the UK.
Understood. Thank you.
Oh, thank you.
I think we can move to our last speaker for today, Dr. Ivan Alexeyev, MD, consultant neurosurgeon from Neurosurgical Department of National Medical and Surgical Center, named after Pirogov. That will be Pirogov team, who are helping us third or fourth time. I don't remember, but it's a great pleasure that you almost every time can attend our webinars. And today, Dr. Ivan Alexeyev will be talking about robot assist implantation of SEEG electrodes in patients with drug-resistant epilepsy. So,
okay, thank you very much. Can you hear me?
Yes, we can hear you and see you, and we can see your screen as well.
Brilliant. Yes, thank you very much for invitation. I represent a big surgical team of our Pirogov National Medical Surgical Center. And today I will tell you about the robot-assisted implantation of DEPS electrodes. So firstly, we begin from the definitions. Of course, all of you know the definition of epilepsy that was adopted in 2005, and the next definitions that was adopted by International League Against Epilepsy. And this is important that a patient should have at least 2 unprovoked seizures occurring more than 24 hours apart. So the drug-resistant epilepsy is defined as a failure of 2 anti-epileptic drug schedules. All patients with drug-resistant epilepsy should be considered as candidates for epilepsy surgery. But before you should think a surgery, patient should go through thorough pre-surgical examinations. The main goal of the pre-surgical evaluation is the identification of the epileptogenic zone. But there is no technique that can help you in the localization of this zone, and we can only make an estimate through the information provided by the other 5 zones. You can see them on this slide. And here you can see that we have a lot of different studies that can help us to identify 2 different zones. So we have 2 main groups of pre-surgical studies: non-invasive, such as standard methods, MRI, video electroencephalography, and neurophysiological testing. And additional methods sometimes help us to get additional information about the epileptogenic zone. And of course, invasive methods that can help us in special cases. The main are subdural grids and DEPS electrodes. 2 words about the history of invasive electroencephalography. The first implantation of electrodes, it was subdural grids, was performed by Penfield and Jasper in 1939. The first implantation of DEPS electrodes was performed in 1949, but it has had a low accuracy because there wasn't a stereotaxic frame. And in 1957, there was first implantation of the DEPS electrodes with the use of stereotaxic frame. There are 2 main methods, how I said previously: subdural grips and stereoelectroencephalography electrodes for invasive monitoring. According to data that we get from different researchers, we can say that the effectiveness of both methods are approximately the same, but the subdural grids have higher complication rates. And of course, you should do a craniotomy and second operation to remove these grids. Historically, subdural grids were more popular in North America, and stereoelectroencephalography electrodes were more popular in Europe. But nowadays, the second method become more and more popular all over the world. And the new era become with the new technologies. For example, you can do an implantation of electrodes with the neuronavigation systems and robotic systems. And today I will tell you about the robot-assisted implantation, and our team uses robot Rosa device. Here you can see the main indications for stereoelectroencephalography. One of the most important steps in the implantation of DEPS electrodes is to make a pre-implantational hypothesis. You have different data from various non-invasive studies that can help you to make an implantation plan. Here, our colleagues, epileptologists, can help us with this. Then we do a pre-implantation neuroimaging, an MRI. We especially interested in two sequences, T1 with a contrast and T2 sequence. The next step is trajectories planning. We use the preoperative planning station, and there are several rules to do these trajectories. Firstly, of course, trajectory shouldn't go through the vessels of the brain. The second is, you can see on the right picture, the angle of the trajectory should be as close as possible to 90 degrees, so it will be more accurate implantation. And the third rule is to get as more as possible of gray matter with the trajectory. We use a frameless type of registration. We use a laser registration of the patient. Here you can see the steps of implantation of electrodes. Arm of the robot shows the trajectory that we have planned before. We drilled a bone with the use of electric drill. Then we put an anchor to this hole of the bone. Then we perform an implantation of electrode and fix it to the anchor. And here you can see the final view of the electrodes that was implanted in the brain of the patient. Here you can see the MRI of patients after the implantation of electrodes. Then we transfer patients to epilepsy department, and then they go through the invasive stereoelectroencephalography monitoring. And here you can see the example of pattern spreading. Okay. This is another example in the three-dimensional spreading of epileptic pattern. So we performed a retrospective cohort study, which included 187 patients with DEP electrode implantation. Here you can see the main characteristics of the study group. The number of MRI positive patients and the number of MRI negative patients were approximately the same. Totally, we have implanted 2,104 electrodes, and the most popular localization were temporal lobe and the frontal lobe. And in the most cases, we performed bilateral implantation of electrodes. The mean duration of operation was 76 minutes or 7.5 minutes per one electrode. And here you can see the entry and target point accuracy of electrode implantation. The malposition of electrode is the situation when the tip of electrode is placed in the another place. It didn't coincide with the preoperative plan, and we divided our malpositions in the 4 groups. Firstly, the first type is an implantation in the brainstem or subcortical nuclei. The second is the place of the tip of electrode in subarachnoid cisterns. The third type is a placement of electrode subdurally on the surface of the cortex. And the fourth is localization of electrode tip in the ventricle. Also, we divided these malpositions into group with impact on next stereo electroencephalography monitoring and with no impact. Probability of malposition in our study group was 2.3 per one electrode. Then we have analyzed the factors that can influence on the development of malpositions, and we found that implantation of electrodes in the frontal lobe is associated with the third type of malposition. It is a subdural localization of electrode, and we can we think that it can be because of the more acute angle in implantation of electrode in this region. And of course, number of implanted electrodes was statistically significant in the development of any type of malposition. So the complications, we used modified Hammer categorization scale of complications in invasive presurgical workup. Here you can see our results, and the number of patients with a complication in the study group was 6.9%. Here you can see the different types of complications visible on MRI: epidural hematoma, subdural hematoma, intracerebral hemorrhage, and in one case we have an intracerebral abscess. It was the only one an infectious complication and the only one the only reason of death in our study group, unfortunately. So the implantation in occipital lobe showed that it has statistically significant influence in the development of complications. We performed 136 patients were candidates for resection surgery, but we made a surgery only in 98% of patients. In 98 patients, we performed resection or disconnection in these cases. Here you can see the types of epilepsy surgery. We performed the temporal, extratemporal resection or disconnections. Also, we can divide the resections into 3 different groups, and in the most cases it was performed, lobectomy was performed. 89% patients have a follow-up more than 6 months, and we can analyze these results, surgical outcomes. In the most cases, it was achieved an angle 1 surgical outcome. And now I will show you surgical outcomes in different types and different groups of patients. For example, in temporal epilepsy, angle 1 outcome was achieved in 81%, but in extratemporal epilepsy, it was achieved in 66%. Results of surgery of MRI positive epilepsy and MRI negative epilepsy were approximately equal. And we there are no predictive factors we found that can influence to the surgical outcomes in our study group. And now I will show you our conclusions. The robot-assisted implantation of DEPS electrodes is accurate and useful method in pre-surgical evaluation of patients with drug-resistant epilepsy. The risks are really low. The time of implantation is comparable to neuronavigation-assisted implantation method, and surgical outcomes of epilepsy surgery based on stereo electroencephalography data demonstrate the effectiveness of this method. So, thank you for your attention.
Thank you for your presentation. Ivan, any comments and questions from the audience? Dr. Mario, would you like to add something?
No, I want to congratulate the team from Moscow. It was an excellent presentation. I enjoyed it very much. Reminded me of my time when I was doing the pediatric fellowship in Great Ormond Street. We implanted a lot of stereo EEG in kids. Well, perhaps one question would be, where in your protocols, where do you remove the stereo EEG? Do you used to do that in theater, in a fully sterile environment, or do you do this even in the outpatient clinic? Perhaps you have a room prepped for mini procedures, something like that.
Thank you for your questions. For your question, we don't do this in operation room under the general anesthesia. We
No,
do
sure.
this in local anesthesia in sterile стерильных условиях.
Wardroom, sterile wardroom.
Да, wardroom, yeah.
So you have something like that in your neurosurgical ward, or do you do it is in the pre-anesthetic room, for instance, in the theater block?
No, in a neurosurgical department.
Department, yes. Okay. I understand. Yes, because one of the problem is that the removal of stereo EEG falls into those small procedures that obviously is a little bit debatable where they should be done. One thing is certain is that if you use theater space to remove them, you are affecting the volume of cases that can be sorted in the operating block. And obviously this has an impact on the productivity. So that's the reason why in Great Ormond Street, we were removing the stereo EEG in the anesthetic room, while other surgical intervention were ongoing in the real operating room.
Yes, I agree with you. Thank you for your question.
No, thank you for the presentation. Again, congratulations.
Okay. Any other questions or comments?
I have one question for Ivan. Thank you, Ivan, for your great presentation. Very interesting. My question about complication, about treatment of hemorrhagic complication. Do you have a cases of hemorrhagic complication which need to remove intracerebral or subdural or epidural hematoma?
Yes, thank you for the question very much. We have two cases. In one case, we had an epidural hematoma, and with the next operation of evacuation of this hematoma, and with removal of two electrodes in this location. And in the other case, we had an intracerebral hemorrhage, and it was located in temporal lobe and was about 40 quadratic centimeters. And also in this case, we performed an operation to evacuate this hematoma and remove with the removal of electrode. But in other, in the most cases, we have hematomas without any neurological deficit, and they didn't influence on our stereoelectroencephalography monitoring.
Thank you so much. And one small question about a number of robot ROSA now in Russia. Do you know about a number of robots now in Russia?
I know that for a long time our hospital had only robot ROSA. Yes, but I know that some hospitals try to approbation of this robot, and I haven't know the last information about this.
Okay, I think maybe this robot only in your clinic now.
Yes, now I think so. Yeah.
Thank you so much. Thank you.
Thank you very much. So just a second. For today, we are done. I think it was a great discussion, and I'm very glad that everyone could come and join. So it's not only about presentation, but discussions, questions, and we got people from Asian part, European part, and I know there are a lot of people who joined today, 26. It's okay.
That's
We
excellent.
also have on YouTube. So thank you to all participants. Thank you to all moderators. Next webinar is going to be 4th of February, and we are going to host vascular session. So who would like to present something? You are most welcome. You can take my email address and text me, type me, so I will be more than happy to include you to the list of our speakers.
Yeah, very good. Very good. Let me say hello. Thank you, Nargiza. You're the reason why it went so well. You put it all together, and you're really starting a good Russian neurosurgery community because this is a perfect platform for a country like Russia that's so big, where you can't go to other institutes, and certainly institutions like Burdenko. Wow. We'd like to see it ideally go to every neurosurgery program in the country, whatever Burdenko televises. And we'd be glad to televise in Russian if you feel you have a good topic that you think the neurosurgery community would benefit by. Just let Nargiza know, and we'll be glad to arrange in Russian. So we just welcome the tool. It's a great tool, and we hope to see all you guys in 2 weeks. So stick around. We'll hang out. We'll network.
Thank you so much.
Thank you so much. Congratulations, everybody. Bye. Bye.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.